Good afternoon and welcome to today's webinar, Contrast Enhanced Imaging, How to Get Started, a Tale from a Facility Like Yours. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, make sure the left side panel is clicked open. At the bottom of the left panel, click on the Q&A icon, and the Questions panel will appear. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also at the bottom of the left side panel is the Resources icon. Click on this icon for a link to today's handout, which include a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left, please note the Home icon. If you experience any technical problems during the course of this webinar, you may click this icon. A tab labeled Technical Support will list a brief FAQ along with the phone number for webinar support. For those who like to take notes during the presentation, look to the right of the slides and click the tab labeled Open. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also registered and logged into this webinar on your own computer so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and the American Society of Echocardiography. And now I would like to introduce today's guest speaker, Laura Johnson, RDCS, a sonographer from Aurora Healthcare. Laura brings 27 years of experience and has experience implementing the use of contrast in the echo lab. Laura?
Hi, I want to welcome all of you and thank you for taking time out of your busy day. And I want to thank IAC for giving me the opportunity to present this topic on contrast-enhanced imaging, how to get started, a tale from a facility like yours. This presentation, as the title suggests, is geared towards labs that at the present time do not use but would like to have contrast-enhanced imaging as part of their protocol. And it's also geared towards labs that may already use contrast, but find that this process, for one reason or another, does not run smoothly or efficiently. Okay, so I want you all to sit back and relax and hopefully enjoy this presentation on contrast-enhanced imaging. It is well known that contrast-enhanced imaging plays an important role in the echo lab and aids in increasing the diagnostic accuracy of the exam. But what I think is not as well known are the processes that need to be in place to ensure the addition of contrast imaging, that it runs smoothly and efficiently. Before we get started, I would like to take a few minutes to address one concern that many sonographers feel. This is really going to slow me down. Even some echo labs that currently use contrast feel this frustration. I actually had an opportunity to present a contrast talk at a recent conference. During a refreshment break, I had an interesting conversation with a sonographer that attended the presentation. As I listened to his story regarding contrast used in his lab, I could clearly see where this component is probably, or this comment is probably not so uncommon. This is really going to slow me down. First, he told me that they had to contact an MD every time they needed to use contrast. And many times it would take a while before the physician would place the order, get in touch with him and then place the order. Then he went on to tell me that once the order was placed, it had to be sent to pharmacy. Pharmacy then would call the sonographer when the product was available. And you know what happens next? He, the sonographer, had to go to the pharmacy and pick up the product. yes, that process will slow you down. What I want to do now is give you 3 ideas on how to make this process more efficient. We really need to try to keep it as simple as possible. First, think about having standing orders. Second, you also want to have a person readily available to start your IV and administer contrast. And finally, it's a great idea to try to identify at the beginning of the study if contrast is needed. Why? Well, there's 2 reasons. This will first help to get the personnel ready, the personnel that are responsible for your IV starts and administration. Round them up so they'll hopefully be ready when you're at the end of your study, so they can help you and assist you in administering contrast and starting the IV. Also, knowing that you'll be using contrast at the end of the study, you don't need to take all that special extra time on trying to image the left ventricle for those function images that are used for your biplane EFs and assessment of wall motion abnormalities. So let's get started. I want to begin by talking about the necessary tools that echo labs need. These are the tools that will help you get started with contrast-enhanced imaging. So where do you begin? I think the best place to begin is to write a policy. Write a policy. This policy, what it will do first is provide you specific guidelines to follow. And these guidelines will make the process clear for everybody involved. For instance, the policy should cover patient orders. How are the orders going to be placed? It will also answer the question on which patient to give contrast to and who can't receive contrast. It will talk about monitoring patients. Do we need to monitor our patients? It will address the question of who does what, who starts the IV, and who administers the contrast. How much contrast do you give? And what method does your lab want to use? And finally, what kind of documentation the lab requires for adverse effects and allergic reactions. Your policy will cover all of these components, providing the sonographers with specific guidelines. Okay, so here's a question that's frequently asked. Yes, you do need an order. And this can either be an order that is directed by the physician, so for each individual case. Now, so it's ordered case by case. So now if your physician is readily available, this process would not cause a problem. However, if that physician is not available, this process could really prove to be quite time-consuming. Or as mentioned previously, you can have standing orders. These orders can have precise indications and contraindications. Because the standing orders contain these precise indications, the sonographer will be able to determine, sorry, I lost my screen there for a minute. The sonographer will be able to determine if contrast is needed. For example, if one of the indications is rule out apical thrombus, and the sonographer is unable to rule this out, the sonographer knows to use contrast on this patient. On the other hand, if this same patient states they've been told they have a hole in their heart, which is a contraindication, the sonographer would know not to use contrast on this patient. So either standing orders or orders that are case by case as directed by the physician is really going to be lab dependent. And it comes down to really what works best for your lab. So let's move on to indications. These indications that will be on your policy. Unfortunately, poor endocardial border definition is not a stranger to the echo lab and is seen in up to about 20% of our studies. The definition is 2 or more myocardial segments not clearly seen. Some more indications are to identify or exclude thrombus, apical hypertrophy. It also helps to differentiate compacted versus non-compacted myocardium, LV apical ballooning, LV aneurysm, LV pseudoaneurysm, and myocardial rupture. Yes, there is more. It can be used to identify and characterize intracardiac masses. It can assist in differentiation of structural variants. This means it allows you to see something that looks abnormal to the normal geometry. A good example of this is if you see like a diverticulum protruding out of the LV wall, structural variant. And finally, it can be used to enhance Doppler signals. Now, regarding Doppler signals, I want you to keep in mind that you'll need to adjust your gains. That is, lower your gains for spectral and color Doppler. You also want to avoid using contrast to assess regurgitant jet severity. You want to avoid it because it tends to overestimate the severity. And just a side note, in our lab, we will use our contrast imaging agent to enhance Doppler signals, only if we've used it for another reason. If the sole purpose is to enhance the Doppler signal, our lab, would choose agitated saline. Okay, so what I want to do now, this is sort of an echo talk. I wanted to throw in a few pictures. We're not going to have too many echo images, but I want to take a few minutes to look at a couple of everyday echo images. I'm going to show you 3 different cases, and what I want you to do is ask yourself the question, is contrast indicated? And for this, the indication is, and it would be in the policy, specifically for apical thrombus. So does the images answer the question, apical thrombus? So this, and keep it, just in your mind, would you use it or jot it down? Because I am going to show you 3, and then I'm going to show you the images, the contrast images. So this is case number 1. And the endocardial border, besides the apex, is pretty clearly seen, but they're really questioning the apex. Case number 1. And this is just a nice resed picture of the apex. So do these images answer the question, specifically apical thrombus? Here's case number 2. Not as pretty of a picture, but this, like I said, these are everyday pictures in our echo lab. And so apical 4-chamber view, endocardial border definition not clearly seen. Can't really tell what's going on there in the apex. And here's the 2-chamber view. 4 images are not infrequent in our echo labs, right? Now, I couldn't find any res pictures of the left ventricle on this patient. This is case number 2, because I can tell you what the sonographer was thinking and how I think. When I know I'm going to use contrast at the end of the study, I do not spend extra time focusing on that LV for function and regional wall motion abnormalities. So that's case number 2. Is contrast indicated? And here's case number 3. Again, apical 4-chamber view. Basal walls look like they're contracting somewhat, but that apex is very unhappy, extremely unhappy. And again, the 2-chamber view. And here again, the sonographer, there was no resed image because they chose, once they got to that apical window, that they were going to for surely use contrast. So that's case number 3. So answer the questions. Was it indicated to use contrast, or did the echo images without contrast answer your questions? Well, in all 3 cases, the sonographers here decided to use contrast. So here is case number 1. Remember what you thought. Case number 1. I like to show this to demonstrate that even sometimes when you're pretty sure there is a thrombus, there isn't, and as in case number 1. Looking at those pictures, I was pretty sure that we would find something there. Whereas case number 2, case number 2, I can guess the sonographer used the contrast to divine the endocardial border. and the apical thrombus was uncovered, probably surprisingly so. Small little apical thrombus. And case number 3, yes. I think this is a nice demonstration of contrast being used to distinguish between what we know now was just apical trabeculation and not a thrombus. Okay, so moving on with components of the contrast, your contrast policy. Another section in your contrast policy should be the contraindications. Sonographers and anyone else involved with any part of contrast imaging really needs to be aware of these. You'll also need to question the patients regarding these contraindications. So it's very important that we become familiar with them. The contraindications are right to left, bidirectional or transient, right to left cardiac shunt. You want to make sure they've not had any hypersensitivity reaction to perflutin. With Optison, you'll also want to ask the patients if they've had problems with receiving blood products, or albumin. And you do not want to inject contrast in the artery. Are there any more questions? Sure. Any woman in childbearing years, you'll want to ask them if they're pregnant or could be pregnant. You'll also want to ask them if they're nursing. And the reason you want to ask these questions is because contrast was not tested on these individuals. It was also not tested on children. And because it was not tested, it is listed as a warning in the packet insert and is not under contraindications. What about documentation? The contrast policy should also contain documentation on adverse effects. Sonographers, and again, anyone who is part of the contrast process, should not only be aware of these adverse effects, but also know where to document if a patient indeed experiences a reaction. One place for documentation is on the report. Of course, we know the report has to have documentation regarding the use of contrast, that contrast was used. But it can also include documentation on the adverse effect. Another place for documentation is, of course, the patient chart. And a side note, the manufacturers always like to be notified when a reaction occurs. Okay, so now you're scanning your patient and you decided you wanted to use contrast. So now what? Well, first, I like to explain to my patient why I needed contrast. This discussion will be why you need contrast, and I actually like to show them their echo images, and I explain to them what needs to be seen. If I haven't found any evidence in the patient chart or on the last patient's echo report, I'm going to talk to the patients and address the contraindications. So for the contraindications of right to left, bidirectional, or transient right to left cardiac shunt, I really don't think the majority of our patients would understand that question. Some might, but the majority probably won't. So what I like to ask them is if they've ever been told they have a hole in their heart. That's a simple question, if they've ever been told they have a hole in their heart. But it's at that point in time I quickly say, I'm not telling you you have a hole in your heart. I ask this question to all my patients that need contrast. I also ask my patients if they've ever had a reaction to perflutin. And again, with my female patients in childbearing years, the issue of pregnancy or nursing needs to be addressed. And with Optison, you'll want to address the issue of blood products, and albumin. Part of your policy should also address the warnings of contrast. I explain to my patients the risk is very low, but adverse events are very rare but can occur. And then I have a brief discussion on adverse effects. If you're going to use contrast, a consent is needed. And this can be either a verbal consent, the patient agrees verbally, or you can have a written consent. If you choose to use a written consent, those adverse events that, instead of discussing them with the patient, that may potentially occur can be part of the and should be part of the consent. And again, this will all be lab dependent. Another question that is asked is about patient monitoring. Do I need to monitor my patient? And the answer is yes. All patients need to be observed for hypersensitivity reactions. Labs also need to be able to handle the adverse event that could potentially lead to resuscitation. But what is not needed now is the additional monitoring that's 30 minutes post-injection on patients with pulmonary hypertension or unstable cardiopulmonary conditions. This was deleted from the box warning. Labs that use contrast will need a fully equipped code cart, including medication that treats allergic reactions, and you must also have trained personnel that are experienced in these conditions of hypersensitivity and potential resuscitation. So right now I want to give you, this is just going to be a brief overview on contrast preparation. And I want you to refer to the package insert and your application specialist. They should be one of your best friends. They're great. They're great to have out there. They're good for a detailed description. Contrast preparation does not necessarily need to be part of your lab protocol. However, you might want to have a statement in your policy stating that anyone administering contrast has been proven competent. So for contrast preparation, you just want to first check the expiration date. Then, as I mentioned, you want to prepare the contrast per package insert. You will need to use a vial mixer for DEFINITY. For Optison, you'll resuspend the vial by rolling it in the palm of your hands. And then you'll need to vent the vial by using either a vent spike dispensing needle or an 18-gauge needle. And then you want to withdraw the product slowly, remembering never to inject air. Okay, so here's the question. What about IV insertion and injection? I might be wrong, but I really think that this is the most controversial question regarding contrast imaging. IV placement and injection? So whose job is it? Probably many sonographers had this thought. I know I surely did. Is it mine? It can't be. I don't start IVs. Well, the task of IV starts really depends on either your individual institution's policy and also the local and state requirements. Will be different where you live and where you work. So who starts the IVs? Well, this will vary from lab to lab, and it really comes down to who's been trained and who's available. So the ideal situation is either having the physician, they can start IVs, nurses can start IVs. If you work in a hospital, hospitals a lot of times have IV teams. Now, the question is, are they readily available? Unfortunately, sometimes they're not. So maybe, not so ideal, but it works, is us, the sonographers. Oh, yeah. So in situations where personnel that start the IVs and are not readily available, yes, a sonographer with proper training can perform this task. Of course, this all depends on your institution's policy, like I mentioned, and your local and state requirements. Some of them will not allow you to, but if they do, we can start the IVs. I personally am extremely fortunate when it comes to personnel. I work in an outpatient setting. I not only have the availability of my physicians and nurses, but I also have 1 to 2 CT techs a day, 5 nuclear techs, and 4 stress techs. These individuals start IVs on all their patients. We actually start IVs on all of our stress echoes, even if contrast isn't used, which it usually is, but all of our stress patients have IVs in them. These people are very, very proficient at starting IVs. In fact, they routinely have the IV in place and is gone from my room before I get the contrast product prepared. And as you know, and if you're not aware, it usually only takes about 2 minutes to prepare the contrast. Yes, this is an extremely efficient process, and I find myself very, very fortunate to have those personnel working with me. Okay, so let's briefly talk about IV training. Let's say the sonographers want to become trained. So we're going to go over some components for IV training. These include but are not limited to knowledge of venous anatomy, what sites do we use, the risks to the patient, such as infection. Are there risks to the IV starter? Sure. You want to take every possible step not to introduce blood to your skin. You also want to make sure you know sterile techniques, you know about infection control, and safety precautions. Knowing the sterile techniques, infection control, and safety precautions will help ease the risk to the patient and the IV starter. So with IV training, once you have the IV in place, the training should go over techniques to let you know that you were successful. And of course, it should also include proper removal of the IV catheter. The next question is, where do I get the training? Well, if you're a hospital-based lab, I suggest you check with them to see if they offer any programs. You can also be trained, depending on your institution, from somebody who has knowledge and proficiency in IV insertion. An example of this is what we did in our lab. Our sonographers actually had this opportunity. Our lead stress tech, who is also a licensed paramedic, set up camp in one of our echo rooms, got one of those dummy arms. She was in there for several days, and we were allowed to spend as much time with her as needed for IV training. Another idea would be to check with the contrast company. They might be able to point you in the right direction. So once you are trained, you're going to have some kind of documentation of training. This can be either in the form of a certification if you go through a formal program. Now, if you were trained by direct supervision like we were, an option would be to have a competency form. It's also a good idea to have periodic skill assessments or IV-in services. This will ensure the instruction that you originally were taught is still being practiced. And this is just an example of the competency form we actually used in our lab. And once we were competent, it was signed by the preceptor, and this form was then placed in our personnel record. Okay, so when you're in the situation where the patient already has an IV in place, for an example, inpatient in a hospital setting, the sonographer still needs to know certain things. First of all, what kind of catheter is in place? The second question is it patent? A great example of this is the day so this was me, helped out at the hospital. Normally working in an outpatient clinic, I'm not used to scanning patients who already have an IV in place. Unfortunately, our outpatients don't walk in with an IV. So I was scanning this patient in the echo lab. Things were going really, really good. Of course, I didn't determine at the beginning of the study if I needed contrast. Why should I? I thought she already has an IV in place. Okay, so I moved on to her apicals and immediately knew that contrast was in the picture. I thought, no problem, my patient already has an IV in place. You know where this is going, right? So I finished the pre-contrast images and quickly went to get the contrast. And always before administering the contrast, it's protocol to flush an existing line with saline. So just as I began to flush the line, the patient told me, oh, that IV hadn't worked this morning, and the nurse was going to give me a new one later today. So I had to call the patient's nurse to come down to start the new IV. The nurse arrived approximately 20 minutes after I called, and yes, this situation really did slow me down. So again, always check for patency sooner rather than later so you can, if necessary, get the IV process started early on. You'll also need to know what kind of medication is being infused. If there's lines of medication bags going in, you'll want to know what's being infused, where should I go with the contrast. In this situation, I just tell you, I say consult the patient's nurse and ask for assistance. So if your lab does not start IVs routinely, here's a list of supplies that we use in our lab: gloves, tourniquet. You'll want alcohol prep. We use 2x2 gauze, 18 to 20 gauge IV catheter needles, the interlink injection site, Tegaderm film. We use the pre-filled saline syringes. We're sort of spoiled. Blunt plastic cannula, and tape. Do you need anything else? Yes, you do. You'll need a refrigerator because contrast needs to be stored in the refrigerator. You'll also need a vial mixer, depending on the product. You're going to need a vent spike or dispensing pen for venting. And or instead of the vent spike or dispensing pen, you're going to need, you can use an 18 gauge needle for venting. Okay. So contrast, dosing, and administration. So let's move on to this discussion. It's going to be a short discussion. Dosing can be either by an IV bolus, you can use a diluted IV bolus, or continuous infusion. Personally, I've had experience with the IV bolus and the diluted IV bolus, but I've never used or seen the continuous infusion method. So for the bolus method, you're going to administer 0.3 to 0.5 mLs, followed by a slow saline flush. For the diluted bolus method, you're going to use a vial of contrast diluted with saline in a 10 ml syringe. 0.5 to 1.5 is injected slowly into the IV line, and this may or may not be followed by a saline flush. For resting studies, not stress echoes, I'm talking resting transthoracics, I like to give the lower of the dose because you can always give more if needed. You have time for that. But again, with contrast dosing and administration, please refer to the package insert or your contrast company website or apps person for a more detailed description on dosing and administration. And here is just the infusion method. I'm just going to put it out here for you guys and let you read it. I won't go through and read it. Like I said, I don't have experience using this, but if you're interested in it, I'm sure your application specialist will be able to go over that with you. Okay. Contrast administration. We ask ourselves this all the time. I'm not sure if I should be doing this. In an ideal situation, a physician or a nurse can administer contrast. However, when they're not available and a written policy is in place, a sonographer might perform this function. Again, you'll need to check with your individual institution's policies and your local and state requirements. But what's very important is that whomever administers the contrast will need to know the proper techniques to use. They should know the indications and the contraindications, and of course, the potential risk to the patient. So those sonographers who are able to administer contrast, they need to be able to demonstrate competency. And I have for you here one example of a contrast competency form that is used to evaluate sonographers who administer contrast. And someone watches over them and checks to make sure that they meet all the requirements, and once they demonstrate competency, this form is then placed in their personnel file. So they know how to open the supply cabinet, they know what supplies are needed, they demonstrate how the proper way to activate the contrast, demonstrate drawing up the saline or using a pre-filled syringe if available. They activate and demonstrate venting of the contrast vial. This is all one page, but I couldn't get it on one page for you. Demonstrate pulling up well, I could, but the fonts would have been so small. So we did it this way. Demonstrate pulling up contrast into the saline and rolling product until blended. Using alcohol pad at the I.V. site, injects diluted contrast slowly. Demonstrates knowing the right presets, turning down the MI, acquiring images and Doppler as needed to complete the study. Demonstrates flushing the IV site with saline. Those are if the IV stays in, or removal of the IV for an outpatient. Watch and observe patient for adverse reaction, and discard all syringes and wrappers appropriately. Once completed, like I said, this form can be used as documentation of proven competency. Okay, so moving on to the next part. That's pretty much all for policy that we're going to go through. Now we're going to move on to imaging. So now you're using contrast, but still there's problems with the images. Well, one possibility is the equipment. What are the machine settings? Another could be the amount and how the contrast was administered. For machine settings, you ideally want to use harmonic imaging. You also want to check your mechanical index. It should be about 0.2 to 0.4. That's optimal. Most of the time, the focus should be at the level of the mitral valve. And there are occasions where you'll move it, and I'll plan to address those occasions. You're going to adjust your TGCs and minimize your near gains, increase your overall gain, and narrow the dynamic range. And what I suggest, if you don't already have one, is a contrast preset, so you don't have to, every time you use contrast, go in and change all this. A contrast preset is a great idea. So call your system application specialist and ask them to put one in your presets for you. It'll just save you some time. Okay, so now your machine settings are optimized. You got it all set, but you're still having problems. Well, these problems could be from swirling of contrast that's seen in the apex. It could also be shadowing or what's called attenuation seen in the far field. You might also see some black lines going through your image, either rib or extracardiac structures causing that black line. And then with color and spectral Doppler, the image just looks a mess, and that's called blooming artifact. So let's look at this echo image for a minute. Just take a look. And you can see that contrast in the apex is just swirling around. So swirling in the apex. Our question is, why does swirling occur? Well, this can occur when the injection is administered too slow. It can also occur if you forget to change your mechanical index and it's still too high. You've got to change the mechanical index, so check that. You can also see it with an improper focal zone. Now we know that in this case the MI was correct. And I said previously that the focus should be at the mitral valve level. However, in cases of poor apical function, it can help to move that focus towards that area of interest, towards the apex. And you will also frequently see apical swirling in cases of a low ejection fraction. So here the swirling artifact is resolved. The apex is, there's no swirling left in the apex. So what we did here is we gave a little more contrast, and we moved that focus up towards the apex. What about this? If any of you out there have used contrast in the past, you probably have experienced this at one time or another. Now, if you do experience this during a routine transthoracic echo, I say no problem. However, if this is what comes on your screen during your peak stress images, well, that's another story. Why does shadowing occur, or what's called attenuation artifact occur? First, it can be caused when the injection was given too fast. We need nice, slow injections of contrast. And this also can occur when too much contrast was given. So, if too much contrast was given, or if it was administered too fast, what this causes is a high level of contrast in the near field, up towards that apex, causing shadowing in the far field. Too much, too fast. So here's shadowing artifact resolved. And how does this occur? Well, you have a couple of options here. You can wait, because it will last maybe a minute, and then it will be gone. If you want it to happen a little sooner, you can try to go in and out of color. You can also try to go in and out of your contrast package. We have a machine that has a cadence. It's called cadence. We go in and out of cadence, the contrast package. It clears this shadowing or attenuation up a little bit quicker than just waiting. But really, the best advice is to try to avoid it by not giving too much and not pushing too fast. Okay, I'm not proud of this, but I want to show you this. This is an example of attenuation artifact that occurred on peak stress images. So you see the resting images on the left, the peak on the right. The resting look pretty darn good, nice endocardial border. Well, not only the person administering the contrast, but also the patient needs to be involved. We need good communication with contrast administration. We, in our echo lab, in our stress lab, always tell the patient to let us know if they're starting to get fatigued. We also ask them throughout the stress test how they are doing. Are you getting tired? We also tell them that they need to give us, we like 90-second warning before they need to stop. So at 90 seconds, we inject, we have them walk 90 more seconds to avoid any chance that this will occur. Well, in this case, the patient had the resting pictures taken, and the sonographer got them really quick. The images were really nice, and the patient immediately began to walk. The walk on the treadmill, and then soon after she said she couldn't walk anymore and had to stop. And really, her heart rate did get up. Not as high as we would like it, but it did increase. So the contrast was given rest. She started to walk right away and had to stop pretty quick. So there was still some contrast in her heart. So she quickly laid on the cart. The sonographer took the images, and this is the result. A lot of attenuation artifact post-exercise. So what this is a nice example of too much contrast, probably. And I wasn't in on this, but I'm assuming that I would think that the stress tech that administered gave it quickly because the patient was ready to dive over onto the cart. So attenuation artifact, okay for transthoracic echo. You have a lot of time. You can wait, well, not a lot of time, but you can wait. It doesn't take long to resolve. But with stress echo, it really can cause a problem. Okay, here's an example of an artifact that appears. You can see it on the lateral wall. We're not really seeing the lateral wall of the left ventricle. There's that black line coming through. It looks like it's coming from some reflector past the near field. So what is this? This is simple. This is artifact caused from either a rib or an extracardiac structure that obstructs the ultrasound beam. For this, and in this case, you can see now that lateral wall, we see the wall coming in nicely. So all you really need to do is adjust your image, trying to avoid that beam that's causing the artifact. Okay, moving on to blooming artifact. This is an example of blooming artifact with color Doppler. You see it with color and spectral Doppler. I unfortunately don't have a slide of spectral, but you can sort of get the idea. So what causes blooming artifact? First, the injection was too fast. You always want to give a nice, slow injection. This will help alleviate the problem. But most and foremost, you'll always want to decrease your Doppler gains, turn them way down. So when you inject too fast, or if your Doppler gains are too high, the returning Doppler signals will be too strong. So what it comes really down to is our signals that are very, very noisy and unreliable. And here's the example. Same patient. And if you look at the color Doppler gain, if you look over onto the left-hand side, you'll see 6. On this particular system, the color Doppler gain runs at 50. So we are almost totally have our Doppler gains down to 0, but we don't, 6, but they're extremely low. So that's how far you need to turn down your gains. And for spectral Doppler. Well, that's it. I hope you all are excited and ready to get started using contrast imaging in your lab. I've given you a lot of, I hope, useful information on how to get started, information on the variables that should be addressed in your policy. We've talked about machine settings. What are the settings that are necessary for contrast imaging? And as I mentioned previously, if you do not already have a contrast setting, contact your system application specialist, get one in your machine. All it would be then is just a press of a button. And artifacts, how to identify them, what are they caused from, and also how to avoid them. I know that this is a lot of information, but I really think that now that you are aware of all these components of contrast-enhanced imaging, the process will run smoothly and efficiently. So I want to thank you very much. And these are the references that I've used for this talk. And thanks again.
Okay. At this time, we will begin the Q&A session. I would like to introduce our IAC team. We have Beverly Gorman, Director of Accreditation, and Frank Vermeeren and Sandy DePetris, our Senior Clinical Specialists from IAC Echocardiography. Frank, Sandy, and Bev will be assisting Laura with the Q&A session today. Frank, would you like to start us off?
Sure. We had quite a few questions regarding shunts and PFOs, and one had to do with what do you do if they just simply have a PFO, and are you able to give contrast? And the other one is what happens if you inject contrast and then find out you have a shunt?
Well, I can tell you what we do in our lab. If the patient does have any known cardiac shunt, we do not use contrast. So I think it's going to be up to the medical directors in the lab, talk to the application specialist for the contrast company. The contraindication is right to left, the cardiac shunt. So a PFO in our lab, we consider that a cardiac shunt. If we do administer contrast and find out they have a shunt, we really don't do anything if they did not have an adverse event, but we would document now in the records that there is a known cardiac shunt, which I would say next time they have an echo, then we wouldn't use the contrast agent.
I have a question. Jody asks, how long do you allot for a contrast study on your outpatient schedule?
We're very fortunate in our lab. We get an hour and 15 minutes for every full transthoracic echo, contrast or no contrast. 45 minutes for a limited echo. So it doesn't matter if we use contrast, if we don't. As a matter of fact, I'm glad this question is being brought up. Really, if I use contrast, my studies take less time because of the system we have in place here than when I do use contrast. And when I don't use contrast. So they take me less, for the most part, less time when I use contrast than when I don't use contrast. Because we do biplane EFs on everybody, and we really need to see the endocardium. We really strive to get optimal pictures, so that might take some time. So I decide right away, no, I'm going to use contrast. I'm not going to take, like I mentioned, all that time to try to bring out the LV function shots that we call them.
And they also asked the question, how long do you watch the patient for an adverse reaction afterwards?
We watch the patient, as, of course, right after we inject, and then just until the patient leaves the echo lab. So that's usually by the time we're done, we take out the IV. We wait a while to take out the IV just in case we might need it. But the patient changes, and usually it's about 10 minutes before they leave. There's nothing really written that I found to say how long it is that you need to watch for adverse effects. In my
question, Laura, says, I'm sorry, what?
I was just going to talk about these adverse effects. What I see here, we use a lot of contrast, and any adverse effect the patient might have had happened immediately. I've not seen one that's happened later on.
Okay, I have another question, and this is a little bit in a different vein. What is the insurance reimbursement when using contrast, and how do you bill?
I do not take, I wouldn't be able to answer that question.
Okay, do you have any idea who might?
I do. This is Beverly, and actually on the ASE website, if you go on the ASE website, and there is a coding specialist, and you can actually email her a question. So if you want to email me, I'll find the link for you to that coding specialist. But she can tell you what codes to use and everything you ever wanted to know about billing. So the ASE is going to be a great resource for that.
There's a general question, or several questions here, about how long does it take for contrast to leave the body?
I would believe it's about 15 minutes, according to my application specialist, to totally leave the body, which brings up a great point that I didn't talk about. If your lab does transthoracic echoes and stress echoes on the same patient, and let's say you do your stress echo first and you use contrast, your transthoracic echoes you're gonna have to wait a while before you start that test, because the contrast will still be there for about 15 minutes.
Okay, and I have another one, Laura. Jody asks, can you recommend a specific protocol for stress echo with contrast? Is there something written somewhere?
Well, for stress echo, it's poor endocardial border. We have to be able to see, most of the segments for stress echo. So as far as a protocol, if the patient cannot see the endocardial border, then you're going to use contrast. I know that's very broad, but I guess I'm not sure of the question as far as how much contrast.
I don't think they meant the policy. I think they meant the written protocol.
Every lab would have their own written protocol, because from lab to lab, it's going to vary. As to maybe they're addressing the post images, like when to inject, how long they walk. Again, it's going to be lab dependent and whatever works best for the lab.
And we had several questions regarding dosing, and specifically, what is the maximum amount of contrast you can give? Can they give more than one vial?
I would really want to probably not get into that because I don't want to misinform anyone. We, in our lab, would never use more than one vial, and I know one vial is appropriate. When we talk about one vial, it's because of stress echo and dobutamine stress echo, because you're going to give contrast at each stage. You might not give the full dose, but you'll sometimes end up using, because there's 4 stages, you'll end up using a vial. After that, I don't see the need to use any more contrast. You know, one vial is way enough, but I believe it's more than one vial. But again, that's why I put look at the package insert. I'm not a application specialist for contrast company, and I don't want to misinform you.
Okay, I have one here. Leila asks, I didn't hear any reference to contraindications in a patient with pulmonary hypertension. Is this a concern?
It's been taken off the boxed warning. It used to be a concern, but now it's off the boxed warning, so you don't have to do anything different than you do with all of your other patients.
And we had another question that's related to the shunting questions. And do you recommend performing a bubble injection prior to injecting contrast, just to be sure?
We don't do that. The contraindication is a known cardiac shunt, so if previously it's not known, we do not routinely do a bubble study, and it's not indicated in anything that I've read.
And Susan asks, do you see a difference between the use of Optison and Definity and agitated saline in your lab?
Well, we would only use agitated saline to enhance our Doppler signals if we did not use contrast. I have had experience with both Optison and Definity. They both are a fine product. One does last a little bit longer than the other. So for stress echo, that sometimes, you know, no, I guess they're both, I don't see a big difference, just that I believe that Definity maybe lasts a little bit longer than Optison, but really they both work fine.
Oh, there's a question here. It's a good question. It's from Nelson. It says, does contrast interfere with nuclear medicine material?
Pardon? Does it interfere?
With nuclear medicine?
No, not that I know of. We have nuclear tests here all the time, and our patients routinely are having their echoes, and then they go on and have a nuclear stress test, and they have contrast injected, and there's no problems with that at all. They go on to have CT scans, no problems with that at all.
One other question that Jody had asked was, how long can a vial of contrast survive outside of the refrigerator?
You can, once a vial of contrast, and I'm going to speak for Definity, is agitated, you can have that as long as it's not vented and put in a syringe with saline. You can use it up to 12 hours. I would say you'd probably, if you're going to not use it, put it back in the refrigerator, and then once you use it, you have to resuspend it, you know, by rolling it in your hand. Up to 12 hours. After that, you cannot use it.
I believe that concludes our question and answer session.
Okay. Well, a special thanks to Laura for being our guest speaker today. Please, everyone, feel free to contact the IAC Echo team with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey, which will appear on your screen concluding this session, and also be available for 3 additional business days at the IACProLibraries.com website. In the upper left, click on My Webinars. Look for the title of this session, Contrast Enhanced Imaging, How to Get Started, a Tale from a Facility Like Yours. Beneath this title, click the link Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.